I'm Burgell, and I'm the mayor of Eureka, and we appreciate all of you being here, and we look forward to hopefully having an educational and an inspirational day today. You know, I was thinking about this, and I've been thinking about this as the mayor's initiative. We've been really looking at mental health education and how we can make change in our region. Because up here behind the redwood curtain, we've really got to sometimes pull it together. We don't have some of the outside influences that others do, which can be a benefit. But why embrace humanity? Why is that the topic today? And I've been thinking a lot about that. And in these times of social media, divisiveness on so many levels, and so many people falling through the cracks, I feel like it's important to speak to our similarities and where we are as a culture. We seem to have forgotten our humanity. We seem to have lost sight of the power of the collective us. And as Joan Borsenko says, no one heals alone. We heal through and for one another. And I really believe that. So I appreciate every one of you coming to be a part of the solution this morning and afternoon. I do want to have a couple of thank yous. This doesn't happen in a vacuum. Special thank yous to NAMI Humboldt and Department of Health and Human Services. They have both partnered with us. This is the fifth of a series, as you may remember. Last year we did 4 different town halls. This year we kind of mixed it up a little bit with diversity. We want to make sure that we're still engaging people and make sure that people are still interested in what we're talking about. So I would encourage, if you do have ideas of topics and things that you are interested in or that you would like to talk to us about, please reach out to us because we're looking for input all the time. Again, I'd like to thank NAMI and DHHS. I know I said it twice, but they've been instrumental in making this a reality over the last 5 sessions. I wanted to thank Eureka Natural Foods again for donating some food and refreshments. They always show up for us. That's why we shop local, right? Local businesses show up for local people. Esmeralda's 2.0, the Flower Boutique, Community Access Project Eureka, and our amazing City of Eureka team who they didn't list themselves, but I'm going to list them. So we have Jacob Rosen, mental health managing clinician. Did I get it right? Managing mental health clinician. Yeah, I'm having trouble with my words today, but we'll get through this, I promise. And then we have Hannah Ozanian over here, and she has been doing a lot of the legwork. She's really been a backbone of this event today. Yep. And we have Laura, who's been a big piece of this puzzle all 5 sessions, so we really appreciate you. Oh, and of course, Laura Nagy, who has shown up to all of our things with NAMI and really been a great benefit. So again, the purpose of this event today, I hope that you will find something that we learn here, and I hope that you will find a lot of inspiration. And with that, I'm going to turn it over to Jacob to talk about procedures and how we're going to move forward. So again, we appreciate you being here.
All right. Hello, everyone. Let me find my position in here because sometimes I stand in front of that camera. So thank you all for being here. Super, super appreciate it. I know the weather turned not great last night. I was a little surprised for such a short storm. So thank you, everyone, for braving it and coming on down. Really excited for today. Just a couple things. We are going to just kind of go over some schedule stuff first. We're going to have our first professional panel. That'll be from, we're getting a little bit of a late start from 10:15 to 11:15. We'll probably end up doing probably about 10:30 to 11:30. And then we'll have a short break for kind of going out, and you can check out some of our wonderful folks who are tabling here today, network, learn more, and then we'll come back for the lived experience panel. And that'll probably be closer to 11:40, 11:45-ish, and we'll go until about 12:30, 12:45. From there, we are providing lunch. So Esmeralda's 2.0 has catered, and they'll be sending over some tacos. And so feel free to have some food, network and kind of get to know each other. And then when we come back at about 1:30, we'll have our keynote speaker, Skid Row CEO Joe Roberts, who has been gracious enough to join us all the way from Canada, which is really impressive. I had the great privilege of getting to see him last year in Detroit. He's a phenomenal speaker. He has a phenomenal story, and I'm excited for everyone here to be able to share with that. Just going over some decorum stuff for the panel. The way that these will start is we will have some seated questions. We'll ask those questions after the panel introduces themselves, and then we'll bring things up for audience to be able to come and ask questions as well. These are different from if anyone who's seen our previous installments of the Community Health Town Hall series, these are going to be shorter. So before we would go for 2.5, 3 hours, we'd have time for lots of questions. Today we're only going about an hour each panel. We'll probably only have about a half hour for questions from the public. And so when you come up, try to be succinct. If you can, try to limit any storytelling before you ask the question, just so that we can kind of get as many questions in as possible and have some great discussion. It is embracing humanity, so please be respectful, right? We're all humans. We're all fellow community members. When you do come up, please be respectful. Even if we have differences of opinion, we want to make sure that we are respectful to one another and that we can hear the other side, because it's only through having these conversations that we can actually come together, learn more about other folks and their points of view, and then learn how to move forward and maybe solve some of these greater problems that our society faces today. Let me just double check. Yeah. Oh, last piece. When you do come up to the podium. The podium does have a microphone. Just make sure the green light's on. And please just give us your first name when you do come up to ask a question. That way, if I need to clarify anything or the panel needs to clarify anything, we know how to address you. And with that, we'll go ahead and get started with our introductions. If we want to start with Dr. Byen.
Hi, I'm Dr. Byen. I'm the Medical and Clinical Director for Waterfront Recovery Services.
Skulian Akoi, Neknau, Gregor Rourke, Metwa Metchuk Morik, SE Nachko, SE Kepel. Good morning, my name is Gregor Rourke. I come from the villages of Morik, Nachko, and Kepel on the Klamath River, and I am currently the Chief of Police for the Yurok Tribal Police Department.
Hi, good morning. My name is Emmy Botzler Rogers. I'm the Behavioral Health Director here in Humboldt County. I am pretty anxious to be here this morning, and I'm glad to be here this morning, and maybe I'll say a little bit more about that later, but nice to see all of you and your friendly faces.
So I'm James Goldberg. I'm the Interim Associate Chief Medical Officer for Providence, St. Joseph, Eureka, and Redwood Memorial Hospitals. My medical experience is actually in the emergency department. I've been here about 4 years. I've been working in the emergency departments at both of those hospitals during that time and was the medical director for several years. So I can certainly give some perspective on the emergency care of our mental health patients in our community.
And I'm Thomas Steenblock, and I do apologize for being late. I am the administrator for mobile services for the homeless and for our psychiatry program at Open Door Community Health Centers.
Thank you, everyone, for being here. So we'll kick things off with those first seated questions. And the way that we'll do this is everyone's able to answer, doesn't have to be in a specific order. And at the same time, if you don't maybe want to jump in and participate on that specific question, you're welcome not to. So the first question is, how has living in such a rural area affected how you work in your field as it pertains to mental health and substance use disorders and homelessness?
I came from Southern California in Los Angeles and retired from there. And coming to Humboldt was a big learning experience for me. And I realized that rural areas have very limited services, unlike the big towns. And it's almost like you have to work like that TV MASH. You need to do what you need to do for the time that you have. And that's one thing that I felt was important. And don't let anyone say that you can't, because you can.
So this is really my kind of first experience in kind of working in a truly rural remote community here. Certainly is eye-opening. I think the kind of just the challenges with even developing services in the community is certainly difficult, and has really kind of poured into the emergency department, where it's kind of, for many, has become the default place of care, which isn't necessarily the most appropriate place for those. So I think really it's building the community resources to help everybody so that they do not need to come to the emergency department if needed. As I say, it does overwhelm the department at times. I think there's a challenge across the whole state. There's a challenge across the whole country. But I think when you're in a rural community like this, it really becomes accentuated.
I would just agree. I think that being rural and remote really puts us at a disadvantage related to resources. And so we're often looking at sending people out of the area to get their needs met. And that is very, very challenging for families, for individuals and families. I do think that the way to do that, and I am have so much gratitude for the people here with me, is through partnership. And we've begun many really valuable and important and challenging partnerships because we can't do it by ourselves up here. And so I would agree there's lots of ways that we have to work together and adapt our practices. And so, from County Behavioral Health perspective, we're always looking at how do we do better in terms of providing access and reaching those really far away remote parts of our community in ways that allow people to get their needs met. And there's still lots of work to be done there, but that's part of the thinking.
And yeah, I want to agree with both the challenges around the amount of resource up here. I think all of the partners are doing everything they can. I think we're getting better over time at really communicating together. One of the challenges in the modern era is the restrictions that laws like HIPAA and specific regulations around mental health information, how they're shared and under what circumstances you can share them, can make partnerships challenging in being able to share, particularly as we have people who move to different places in the spectrum of care. For instance, on the mobile van with the folks that we're serving who are experiencing homelessness and low resource levels, some 70% of the patients, the last time I ran a report, had a mental health disorder, substance use disorder, history of trauma, history of abuse or neglect, or all of the above as part of the profile of the situation that they're in. And so for these folks, a lot of times they're either in a place where they're a little more stable, they're at a lower level of acuity, so there's something that we can handle. They may move to a higher level of acuity, which is much more appropriate for the resources at the county and the hospitals to be able to help us with. And as people move back and forth, being able to make those transitions of care can be really challenging. And this is where direct conversations and partnerships have come in really handy. And as we get better at doing that, at learning how to work within the regulations as they are to really bring treatment to people. So, because for the patient, for the person in question, and for their families, hopefully it'll be seamless. Hopefully as they move from one theater to another, whether it's the emergency department, the county, or us, their care for them, it can just be one thing. They can just get taken care of. We all know who you are and see you as a real person. And so trying to develop that system is one of the things that I think is really important for us at Open Door right now.
And then from a law enforcement perspective, being from a small community actually really enhances what community policing is. So I know that's one of the big buzzwords, especially in the police reform movement, but it's not some acronym that gets taught in a classroom. When it comes down to it, community policing goes back to the basic Peelian principles of law enforcement of neighbors policing neighbors. That's what community is. We have lost sight of that, I think, over generations. And communities, quite honestly, are saying that they are tired of it. They want something different. They want change. And with small town law enforcement, we actually have a degree of support that a lot of other larger metropolitan departments don't have, because we're forced to actually live in the community that we work with. We're forced to be able to engage off duty with the people who we have to work with professionally. Our kids go to the same schools. We're going to attend the same events, going to see them at Safeway. So it definitely changes how you do law enforcement when you work and actually live and are part of the community in which you do that work.
To tag off of that, I want to say how powerful that law enforcement relationship has been for us as a healthcare team. Having officers be able to come to us knowing that they can bring someone our way and that we can be a gateway to care has been incredibly powerful. And that two-way, being able to communicate back and forth about how can we help somebody that we mutually serve has been a game changer, honestly, for us. I also have found that officers seem to show a lot more satisfaction being able to bring somebody who they know is sick for care instead of having to the only other option is like there's a disturbance. I can put them in a cell until they calm down, or I can go get them help. And the fact that they are moving this whole model towards bringing them for help, I think is benefiting the community as a whole, lowering costs, making it easier for officers to move on to the next thing that they have to do. And I've been really grateful personally and both professionally for the amount of interest that law enforcement has shown in really trying to partner with folks to be able to do this as a team effort in the community.
And I'd like to echo that, especially with the EPD and the work that we've done from the very beginning. We started waterfront recovery. And the very close relationship that we have dealing with mental health and people who are addicted has been a great challenge for both, but the two together has created some successes.
I'll just add one more comment. And echoing all that's been said, I do have so much gratitude for the leaning in of all our partners in law enforcement, especially in all the ways that are already reflected or stated here. And I think I want to kind of underline how in a small community, in a remote rural community, there are relationships that don't exist in larger communities. Like you referenced, people go to school together, like we grow up together. I have relationships that I established as a child that I still have now that are part of what gets leveraged in the partnerships that we build. And so that's, I think, such a strength that sometimes gets forgotten in small communities.
And I just want to add one more thing. And I do want to highlight one of the programs that we have going right now, which really, is the epitome of what we're talking about, and that's the CARE program that Jacob is so wonderfully leading, where law enforcement is that first line, along with our mental health workers, who instead of seeing somebody who is in a mental health emergency, if they determine they don't need to go to the emergency department, but that what they need is resources, they are helping direct them to those resources and assisting them in getting them there. So kind of in that way, you're helping them, you're helping to maintain their dignity as well. And I think that is way more valuable for them necessarily if they are not in acute crisis, that they are able to have assistance in accessing those resources. And I say law enforcement is that first line, almost, more often than not. So we are very much appreciative of them, and I say we're also appreciative of the work that Jacob's team has been doing.
Well, thank you for the shout out, Dr. Goldberg. I appreciate that. I think it really forces creativity and it forces innovation, right? And because, like you were saying at the beginning, Dr. Byan, it's kind of like MASH. We just have to get the job done to some degree. And so we have to figure out how do we develop these relationships and get creative in how to serve the folks that we're serving. In thinking about that creativity, can the panel discuss a situation where they found success, maybe in one of those collaborations, or maybe there was a really difficult situation that was coming up, and through some of that again, ingenuity and creativeness, and a positive outcome was able to be achieved.
So I do want to start with the CARE. I don't have a specific encounter for that, but when we look at there's been a lot of education done that has, with law enforcement in the field on kind of what is the appropriate use of the 5150 behavioral health hold. We've seen a great decline in the number of those that are written because of the fact that people are getting to more resources, then there's this better education kind of over that. And as I say, the decline has been quite staggering, and that's not a concerning decline. That is actually a good decline. That means that you are now treating people appropriately rather than just like, oh, they have a mental health problem, let's just bring them to the ER, we're going to put them on a hold. And if they're not actually meeting the letter of the law, of the LPS law, then you're kind of really, you're really kind of violating their rights. And so it's kind of educating those first responders kind of on that, and then having this other team that is going out to get people to the appropriate resources. You're really kind of seeing those 5150 holds go down so that they are now just on the ones that truly, truly, truly need it. I mean, the decline has been quite staggering, and I think that has been an enormous success for our community.
I think I'm going to jump in with some. So, one thing I'd like to ask the crowd and people listening. So, by show of hands, and don't be afraid, how many have had an experience with law enforcement where you walk away thinking to yourself, friggin' cop? Yeah, me too. Just last year, and I was in uniform, and I thought that. So I think what it really comes down to it is the simple question for that, that creativity is like, can we do our job better? Yeah, we can. And we should strive to do that. And that's kind of what this entire process is in collaborating and working with partnerships. Because before cops, we were really almost like 13-year-old kids with our defenses. Someone says, you don't know what to do with your job. Boom, that wall goes up and no one's getting around it. And so we had to work with our partners to be able to understand and have mutual education of what we do. And so one of the things that we've been very fortunate with here in Humboldt County and now moving up into Del Norte County is working with behavioral health, working with NAMI and law enforcement in our CIT program. And with CIT, it's crisis intervention techniques. And this is something that can offer law enforcement a tool. We wear the vest, we wear the belt, and when we go out to a call, what we look for is a tool to be able to deal with that situation, because we have usually about 5 to 10 calls waiting for us in the queue. So we need a tool to be able to deal with that. But yet it's already been established, we're that first response. And so oftentimes that rapport that gets set is when somebody's in crisis. And if we don't have a manageable way to deal when someone's in crisis, to be able to lead them to get the help that they need, it's not going to happen. And it's going to end up leaving that bitter taste of the law enforcement encounter. So working with our partners to be able to provide that education of how we handle a call or how we perceive the call. And then with that, we can learn how we can actually do that better.
One situation that I can remember, which was actually during the first couple of years that we had at Waterfront. By the way, who among you know about Waterfront Recovery Services? Okay. I just wanted, because we don't advertise, we just work. It was, and again, talking about the community police services, they're the first line. Most of them know who the chronically mentally ill. They know who are chronically substance abuse problems, the homeless, and so on. And one of the wonderful things that we did during that time is, and I actually know this patient from mental health, but he's not eligible for 5150, but he's actively psychotic. He's meth intoxicated, and his health was not that great either. And so they were brought to us by EPD, and actually they were very good in dealing with the crisis with this specific patient. And we finally got the patient, because we don't force medication. we were able, with the help of the law enforcement, to talk him into taking medication to chill him out and to start the process of admitting him for detox, and at the same time to take care of his mental health. We deal with dual diagnosis or co-occurring. We deal with substance abuse, and to many extent we deal with some medical problems as long as it's not beyond our capability. And at the same time, we were able to work with the case management from mental health. And I have to say that, he stayed with us for 90 days. Finally, his family got reunited. His children from Hawaii came, and they were, it was a great reunion for them. But that's what the community cooperation and work did to this person who likely would never had a chance.
For us, while I obviously want to be careful about talking about individual cases, lest somebody be recognizable in that and protecting people's confidentiality, I can't actually count the number of times this has happened with the teams here in Eureka, with law enforcement, and it's happened also with law enforcement in Arcata, where someone will be escalated, it's being brought to their attention, someone's complaining, they come to talk to the individual, and the first question they really start with is, so tell me what's going on. And in that process, what they discover is this person has an unmet medical need, unmet mental health need, unmet social services need, and they're able to bring them to us and say, hey, this is what's going on. Are you guys able to help with this? And if we take it on. If we're not, we know how to get them hooked up with the people that can. This both allows the police officers to move on because it doesn't need their further intervention. They've done the right thing. They've brought the person to where it can begin. And Open Door, we try to be that gateway even to other services. We have robust partnerships with DHHS, with social service providers within the community, housing providers, and so on. And we have our own ability to provide things. And many times I can think of one time there was a person that was really, really agitated and they were really angry and they were acting out, and the police interact and they ask what's going on. And what it turned out was they'd gone to the pharmacy to get a very important medication, and the pharmacy was saying they couldn't refill it. And this person really didn't know, because of their situation, because of where they were with their mental illness that day, they couldn't really navigate the system to be able to get this thing taken care of. And they were able to bring them to us, and we were able to tell them, look, we'll take care of this with you. And we have crew, we were able to go and actually interact with the pharmacy, get it taken care of, get it cleared up, and get it for them. That person didn't need to go to jail. They just needed help. And law enforcement recognized that and brought them to us. And that person's problem was solved for the day, and everything worked out. And so it's time and again I've seen that happen. That's the thing, is that's not just a one-off thing. That's not a small, victory amongst many things in our community. That's a regular pattern that's been emerging in our community as law enforcement has come to the table with all of us who provide healthcare and social services. And, I really want to give a shout out to that we continue to support, encourage, and ensure that law enforcement is funded to have the teams that can do this.
The example that's coming to my mind is really about meeting people where they are. And is that better? Okay, thank you. The example that's coming to my mind is really about meeting people where they are. And I'm thinking about an experience that happened really several years ago now with some minors, some kids who needed treatment in the southern region of our county. And we were having a really hard time connecting with them for lots of reasons. Besides the fact that they were so far away, there was pretty profound distrust by that community of our organization, understandably, right? We're a government organization, and why would they trust us? They don't have reason to. And so we actually partnered with the schools, and I want to just acknowledge the importance of the role of education in the work that we do. And we have just really amazing partnerships that I think have served our community well with education, and the Office of Education in particular. But at the time, we partnered with schools down in the southern region to do some warm handoffs. So we had staff that then went down to the school campus, and then the staff at the schools who had relationship with the families helped connect us. And so then families were willing to come and meet with our providers and allow their kids to be seen. And so that was just such an important reminder from my perspective around meeting people where they are, but also respecting the mistrust or the need to develop relationship and demonstrate that we're going to be consistent, and we're going to show up, and we're going to be there in ways that feel safe. And that's what this work is about too, that if we're able to meet people where they are and just build relationship, that's when we're going to engage and begin, and as we're already seeing, to prevent that escalation that leads to crisis.
Thank you, everyone. And just adding on to that, the human part, the human element, right? We're humans working with humans, and having that relationship is so important. And in talking about that relationship, acknowledging that we're human too, and that actually leads into the next question, which is, this work can be difficult. And the next question is, how do you as providers in our community take care of yourselves so that you can continue to bring that compassion to your work in serving the folks that we serve?
I can start with that one. It is difficult. It is certainly kind of, in the emergency department, you have the stresses of all of the other, I'm just going to put it in quotes, air quotes here, but, the medical emergencies, because ideally, like behavioral health, I think the paradigm is starting to shift that actually, like, behavioral health emergencies are medical emergencies. They're not separate. But it is stressful to work in there, in that environment. And it is absolutely critical. Even when I'm in the department, I'll go step outside in the ambulance bay and take a deep breath. I'll just go just to decompress. I'll go take a walk to the cafeteria to get some food, come back. I just have to step out of the department just for a few minutes. And then it's having your colleagues by your side as someone to kind of help decompress with as well. And then when you're off, it's really kind of finding things that you really, truly enjoy doing. It's Humboldt. There's a lot to do out there. Maybe not today outside, but in general, it's there's a lot to do here to kind of help for your own mental well-being. I think the recognition that healthcare workers are kind of immune to those stresses and just need to kind of just tough it out. I think that paradigm's really falling. I think really it's, recognizing that those that are caring for all of these patients are also having their issues as well. And so I think we're starting to see more recognition of that as well. And just from the organizations that are employing them, from the, whether it's the hospital, whether it's the medical group and, the local medical group that's kind of employing the physicians, there's really been a big recognition of that. And it's that in turn will kind of translate to better care for those medical patients.
What feeds my soul is when I see a patient who's so broken, so very broken, and 3 days after, you see their face, you see their eyes, and there's life there. That feeds me. That really feeds me. And so I know that there are a lot of times when we're about to pull our hair, but then you see that same person, doing well, and especially thanking you. That is so, so wonderful. And of course, I see my grandchildren every month.
I have a lot of thoughts about this area. I'm so grateful that you said behavioral health emergencies are medical emergencies. I appreciate that very much. I feel like and what you said about how care providers are often tasked with creating space for healing and recovery, yet they're struggling themselves with healing and recovery. COVID was such a great example, right? Like everybody's impacted and terrified and worried about their health and their family, and yet they have to make space, either emotional space or physical care space for others struggling. And I think it gets overlooked so many times and is just so important. Part of why I said at the beginning is that I was feeling so anxious is that part of how I do self-care is trying to be authentic about my own vulnerabilities, right? Because that's what allows me to be present with others for theirs. And I do feel like we are all human. That's what we're talking about today. And we all suffer somewhere on the continuum. And so to be able to recognize our own suffering is how we make space for other people's suffering. I was at another event yesterday with Chief O'Rourke and others, and one of the questions they asked us was, what's a word that comes to mind for you when you think about crisis? And there were so many amazing words from that group, but one that came up for me was, or two I actually shared, was vulnerability and intimacy, because that's how we engage with people, right? Whether it's in crisis or just in day-to-day life, it's by being vulnerable, and the intimacy that comes from that, I think, is where the healing comes from. So I do lots of self-care things. I go running, I meditate, I ground and center and all those things. And I also look for ways to connect with people and build community and have relationship with others who are doing this work and recognize the challenge of it, but the good intent that we all bring to the table. So I'm really grateful for this conversation.
I also have a lot of thoughts on this too, because I think one of the things right now that's going on in the country is officer wellness and that movement of law enforcement taking care of themselves. One staggering thing that I heard was at a training, the average person in their life experiences about 5 critical traumatic events. At the end of a 30-year career for a law enforcement, their average is 805 critical experiences that they have. And what we're learning about trauma, including that vicarious trauma, is it stacks. It's not linear, we're just ... it stacks. So it's like one, another, and it just weighs down and compounds. It just gets worse and worse and worse. And we in the profession, we're terrible about taking care of each other. Every single officer has a story of some slug in the department that they've worked with or seen, and it's always, that person used to be a good cop. Well, what happened? We don't take care of that. We don't look after each other, and now we are starting to, and we're behind the game on that. And so when I was in my career, you couldn't express when something bad or negative or you were feeling these emotions out in the field and as having an impact on the call. It was suck it up and move to the next one. Well, I mean, we can't afford to do that anymore because we're learning the negative and the compounding impact of that trauma on us as officers, and it's having an impact on the community that we serve. And so we are trying to be better with that. And so with that, for me personally, I found a couple of years ago that I was actually kind of going through a depression. And so my wife flat out says, you're acting and displaying signs of depression. And it hit me. And so I went out and started seeing a therapist, and I was actually open with my staff about it and told them about it. And from that, I was able to remember the things before I became a law enforcement, what made me and what I enjoyed. So getting excited about certain things like, prepping for going hunting or getting ready for a fly fishing trip or participating in ceremony and our cultural events. And then I'm going to out myself as a colossal nerd. I went back and started playing Dungeons and Dragons again. So and I'm having a blast doing it. So, and my office teases me unmercifully about it, but I don't care because I'm enjoying it.
Right on. Shout out for Dungeons and Dragons, man. I'm with you. 100% with you. And I really like what was said about vicarious trauma in one way or another by everybody here. You know, for those who aren't familiar with that term or the idea of it, it is if you are there listening to or witnessing someone else's trauma or listening to the story of it, the same part in their brain that is lighting up as they're telling you that story, as they're engaging with you, is lighting up in yours, which means you're experiencing to a lesser degree the trauma with them. And that the impact of that over time on people who work with this repeatedly, I think of, I've worked both on the front line and now supporting a team who's on the front line. Our mobile team in particular, every single patient they encounter is experiencing trauma. Being homeless is a form of acknowledged form of trauma. Add everything else that's going on with them, the violence that they may experience, the deprivation they may experience, the challenges with their health care they may experience, all of those things together. And my team experiences those every day. And so in doing that, how do I help support people in that? And how do I help support families when they come to us for advice and everything? And part of it is community. You know, for my own self and trying to maintain my own thing, I'm fortunate enough actually to be a person in recovery, which means I have a huge family of supporting people around me who are there that I can turn to and who have tools. We share tools. We share what works with each other. And that's one way in helping create that idea within my team using the tools that the medical field has to offer, that our behavioral health providers have to offer, and that are out there is part of that. Part of it is also really recognizing that you need to have both work-life balance. And if jobs can be structured, and this is very challenging for law enforcement, it's very challenging for the ED and for county, but to ensure that part of everyone's working time isn't doing work with people experiencing trauma for some period of time so that we can step away, you know, when we go home, helping people find tools so that when they leave, work stays there. Because you're not going to solve that person's problem at 2 a.m. while you're laying in bed when you should be sleeping or enjoying your family or any of those things. And so trying to help create a sense of this, as well as creating both in families, in the people that we work with, and in the community at large, to be supportive of the folks doing this work. They need your support because they're facing this on the community's behalf. Those who are at the front line are choosing to be there to try to help this so that our community can be a better place as a whole. And so giving that support and acknowledgement, just the knowledge when people hear that you appreciate their work, that you thank them for what they've done, you know, especially in light of how hard it actually is. If you've ever tried to picture what it's like to be, especially, I look at folks who are right on the front line all the time. You know, I work in a different relationship to some of the work now, but when people can hear that their work is appreciated and meaningful, it takes some of the weight of that trauma away. It validates what they're doing. And when you can give that to people, validation that this is the right course, you know, it gives them a tool and a resilience for next time. Resilience is like a gas tank. If you're constantly draining it, you can't stop at the gas station to fill it up. So we need to find ways to help people fill that tank.
Thank you, everyone. It was excellent discussion and input. With that, we will open things to the public for questions. And so if anyone has questions, go ahead and line up on the right, my left, your right side of the room, and then we'll call you up. Thank you. So does anyone have any questions that they want to pose to the panel? Yeah, come on up to the podium here. Is that microphone on? Yep. Oh, down just a little bit. There it is. Green light's on.
Oh, okay. Got it. Thank you, Kim. She's technically astute about these kinds of things. My name is John Ash, and I'm wondering about the use of video examinations in the mental health. I was recently referred to for therapy up in down in San Francisco, but there was nobody up here, so I was referred to a therapist in San Francisco. Are you utilizing video exams more? Is that something that's being adapted?
We do use telehealth. County Behavioral Health does use telehealth, and I know other organizations do. I believe Open Door and others do. And yeah, we adapt it in a way so that it's effective. And also, we need to ensure that that will work for the client, right? So the patient needs to feel like that's an effective mode of treatment. But yeah, we do that both with medication support, but also with therapy sessions. That the person does an assessment, that an evaluation that kind of vets for all those things. Will this work for this particular individual? And then they get set up with the therapist, and they do it through telehealth.
And is there an emergency app that if a person is stressed out or needs the help, they can go on their smartphone and go face to face with somebody that can help them?
I think there is that option, but we don't have, like, County Behavioral Health doesn't run an emergency through telehealth. We have our own emergency access line and our facility here locally. But I don't know if there are other emergency apps that people can use.
There's a number that are available kind of online. I hear ads for them all the time between like podcasts and so forth. They are available. I don't think there's, as Emmy said, there's nothing like county specific here. They are useful. I think, actually, Mr. Ash, I appreciate your question, because this is really the way that kind of medicine is kind of going, and the way that we're able to bring care to rural areas like this, where we don't always have the resources physically present here. In the emergency department, we do use telepsychiatrists to evaluate all of the behavioral health emergencies. They all get an evaluation so that they can then give the emergency department recommendations on treatment. So we're at least initiating the treatment before they're even placed in whatever their destination is going to be. We're expanding this to other areas in medicine as well. You know, they're developing this. It's really kind of the wave of kind of how things are going to be, not just here across the country, but I think in a rural area like this, it is a way to bring care when the resources are not physically here.
Thank you.
Just to add to that, Open Door is indeed, just like with the county, doing both psychiatry and behavioral health through video. And because of that, we've been able to add an amount of access that we could never have added, trying to hire providers in this region. You know, people got to want to come live here. They've got to often find work for spouses. There can be a lot of challenges for recruitment, and being able to expand to this not only has brought up the number of people that are available to see folks who are in need, but particularly for our low resource patients who, in Humboldt County, one of the number one things we hear on the social service side of what people need and don't have is transportation. The ability to actually get to an appointment. And by offering them telemedicine to their home, because an overwhelming number of people can either get to a smart device with internet connectivity or have one. And so we've been able to expand the number of people, or people who are homebound. Perhaps their health actually keeps them in the home. Perhaps their mental health condition keeps them from being able to leave their home. We can now bring care to them where they're at. It's been a huge revolution for many of our patients. And as we're continuing to expand that, the other thing is for those who are homeless and don't have any of those resources, we have set up certain rooms at Open Door clinics, and we will actually bring the person to the room, let them use our gear for the visit with their outside video provider. So it's been really, really helpful. As far as the emergency apps, I don't think there's anything specific to our area, but what there are for many people, your insurances, if you have private insurance, check with your insurance company. Most of them carry these kinds of services, including behavioral health hotlines and various ways to interact, because they realize the value in that. And so, and there's quite a few companies now that for very low for low income or higher income people offer online urgent services.
So my name is Danette Kellerman. I am a social worker in the area. I wanted to say, first of all, sorry for clapping, but I got excited to hear that the police officers are actually thinking about the trauma, because every time I look on Lost Coast and see all the stuff that police officers go through every day, or not go through, they walk beside our community every day I think about all the trauma that they, like each one of those calls is potentially dangerous and scary. And so I get excited because especially over the past couple of years when so many things have happened with police officers and bad situations. The other thing I wanted to talk about is twice I heard in this conversation this morning about how we have to do things. We don't have to do anything, we get to. And for me, that's important because if I have to do things, that means I don't have a choice. And so I get to work in this field, I get to walk beside people, and I get to help people with mental health issues. And I'm a person with lived experiences who was told 29 years ago that I would never work and that I should apply for SSI. And so, I think it's really important that we, the way we talk with people and some of the words that we use has a little bit more compassion about, and the thought of sometimes people just.
Danette, I'm sorry to interrupt. I do just want to be conscious of time.
Okay.
Do you have a question that you wanted to pose? Or, oh, okay. Sorry about that.
Can I respond to the comment?
Absolutely.
Please don't apologize for clapping for cops. We usually receive a different hand gesture. So everyone claps for the firefighters and no one claps for the cops. So please go ahead and clap for us. I love it. Remember, you can do it again. Yeah. But one thing I would really like to address with that though is the importance of understanding officer wellness, because understanding how that trauma impacts us is a very easy and direct translation to understanding how trauma impacts the people who we serve and the communities. And by understanding what a trauma response looks like in an individual and understanding what a trauma response looks like in a community can actually help law enforcement reestablish a trust and rapport with the ultimate goal of still holding people accountable, but holding them accountable with compassion and understanding. So there's a direct correlation.
I just love all these C words and B words. I'm Holly Klingel. I recognize quite a few of the people in this room because I've been doing the NAMI dance since about 1996. This is just wonderful, and I do have a question. How soon, how can we implement the new definition of gravely disabled? That definition, as I say, I missed the beginning because I had to park so far away. Thank you, Rob Barkley. And it's so important. It's something, first time I read that definition, I went, oh, let's see, I can't think of all the words I can't use. So if you're going to address it specifically later, fine. But if not, how do we, I know we can't afford it in Humboldt County for a couple of years, but boy, do we need that. And it's such a giant leap forward to have it. Thank you.
I can say a couple comments about that. I think hi Holly, nice to see you. I think you're asking about SB 43. Is that right? The change to the legislation. Okay. We requested a delay in implementation for that until January 1, 2026. And so the intent of that legislation, I think, aligns with your excitement, Holly, that, we can better care for our community. We can better take care of people who are suffering in this way. And there's lots of complexities to that legislation, including it allows for placing people with severe substance use disorders on a conservatorship. And some of the challenges with that are that we don't currently have facilities that do that work. And so it potentially sets us up for additional backlog here locally in our emergency rooms and in other places because we have nowhere to send those individuals needing treatment. There's some other things like, from my own perspective about it that can be challenging, and it's a very well-intentioned piece of legislation. So the reason we asked for delay was because we wanted to do our best to put in place the structure to really respond to that requirement in ways that would be effective and not just leave our community more vulnerable and kind of out there lacking resources. And if others have something to say about that, I would certainly welcome.
Yeah, absolutely. So like I know with the hospital is going to be kind of partnering with the county, partnering with Waterfront, just because this is such a kind of broad reaching piece of legislation, so that we are all together and in creating a plan that will work for the community. Because right now, as I said, the resources really are not there to kind of handle the increased numbers and kind of increased scope of the legislation. So the 2 years is, while it seems like it's a long way off, it really is not to develop. And so we're going to be quite aggressive and kind of partnering together to come together, develop a plan so that we can address the broader scope of SB 43.
Yeah, Open Door very much shares the opinions with those two there. Our concern is that, again, that the resource doesn't exist. What happens to the individuals caught up into that system without those actual resources in place? It's one thing to say that the intention is to ensure that people with, severe substance use disorders get treatment. It's a whole other thing to have treatment available. And if you don't, what do you do with them in the meantime? And that could put that person actually at greater risk, as well as, taking away human dignity and a bunch of things that really need to matter just as much as we try to address the problems. And 2 years is almost no time to build a really robust infrastructure with services that don't currently exist. We don't have facilities in which a person must stay, but the focus is substance abuse treatment. They don't really exist in California. And so while the law was crafted with good intent and the idea of really finally addressing the problem, it didn't come with any support for building the structures that are actually needed to do what it says. And so we're grateful for the delay and want to be active partners in creating what our community solution is to that. This regulation could be most impactful, honestly, on rural areas like ours that are already low resource and where it's difficult to draw down further funding to build out and extend our infrastructure to kind of meet that need.
Do you know if other places have done that?
I know, so Michael Kellerman is our new CE, came from SLO, and they actually just started right away. They did not delay it, and sounds like they are struggling a bit right now with the resource problem. And as I say, there are counties that have started already, and they are struggling a bit. So I am very, very happy that we have 2 years. I'm also nervous that we only have 2 years.
Yes.
But, obviously there's, we'll all kind of come together so that we can kind of address the problem at hand.
Hi. First, my name's Leah Nagy. I'm president of NAMI Humboldt, and I'm just so pleased that the panel's here and we have this town hall meeting. I've been involved in mental health for 25 years, and what was at the beginning is so amazing now what we've accomplished in our community. So I feel really fortunate to be in Humboldt County and be part of a community that really cares. So again, I want to thank you and the Lived Experience panel coming up, and Kim and Jacob and everybody, the dream team that got this thing together. But I have one really cool story that happened probably 10 years ago. And because of Cal Poly, Humboldt State, I work a lot with families who have children with first breaks. And I remember I've worked a lot with Heidi at Arcata Police Department with families. And we had this young kid that needed involuntary treatment at Sempervirens. The kid didn't want to go, and Heidi promised the young man a pair of tennis shoes. And so he voluntarily went to Sempervirens, got help, and Heidi did deliver the tennis shoes. So that's just a little minor story of how important it is for the community to work together and try and make Humboldt County a better place, a safer place. And again, I'm glad to be here. Thanks, guys.
Thank you, Leah.
Hi, I'm Kim Johnson. I'm Executive Director of Wintong TRTF. I have a question on 5150 clients, the ones struggling in silence that nobody knows of. I just had one go Sunday and 5150 by the police, and then they get released. How, they can present very well, and you don't know this. How do we deal with the ones that are silent, struggling, and in crisis? I had this client attack 3 clients and a staff member, and then they want to send them back to me in 2 days. I'm out there at 9:30 Sunday night because I have 22 people. I have to calm down now. How do we deal with them getting released on from a 5150 when silently they are a danger to others and basically to themselves? But they don't present that, and you don't see that until it happens. And then we're struggling again, and can I bring that person back into my facility? Technically not. But by state licensing, I have to. So with the county that I work with, they're amazing. They step in and they, at 4:30 in the afternoon, help me out and deal with this. And no, this client didn't come back. But it's the fact that if I didn't have that, this client would have came back, and I have very traumatized clients now. All of mine are mental health, and a lot of them are conserved, and they don't have the choices. So how do we deal with that when we know they're in a crisis and they're silent, but they're getting back released?
So I think there's kind of 2 parts for that. I think the first part is, just kind of what's happening. I can only speak for the emergency department. I can't speak for Sempervirens or any of the other places. I know at least in the emergency department, like every single 5150 is getting evaluated by a psychiatrist. So they're getting evaluated. So they're seeing the specialist, and if they're determining there's not actually like hold criteria, it's, then we're going to go kind of with what the specialist is actually saying. But everyone has a telepsychiatrist evaluation. I think the bigger issue at hand is actually a question of stigma, and the people who are, because of the fear of being, told that they have a mental health diagnosis, they're afraid to speak up. They're afraid to say what is actually going on with them. This is all too common. And really it's about breaking that down, removing that stigma, and treating this, as like any other kind of, medical problem. Someone say, "Oh, I have diabetes. I gotta get something to eat. Sugar's feeling a little low. I have diabetes." Someone needs to kind of say that, yeah, I am struggling. I am having a problem. I am depressed. I am extremely anxious. I'm hearing voices. Like, I think and to create an environment, a safe environment for them to be able to speak about it to anyone, not just advertising the public, but to be able to go to, a provider and say, "Hey, I am struggling. This is an issue." So I think that's kind of the bigger issue here right now, the global thing, which is going to take obviously a long time to to address, but I think it is, that stigma is, I think, is starting to come down. Okay. But as said, that will take time. So I don't know if anyone else has anything to say on that.
I agree with what you're saying. And, 5150 holds have very specific criteria. So danger to self, danger to others, gravely disabled. And it is based on the judgment of the clinician or the provider doing the evaluation at the time. Often within county behavioral health, we have somebody do the evaluation and then they get a consultation, like they talk to their supervisor. So we're not just we're really trying to be as thorough and robust in making sure that those are accurate evaluations. And the bigger question is, what is the treatment need for that individual? It may not be that they need to be on a 5150 hold, but there's some other treatment that needs to be engaged in, and it's not happening because of stigma or because of other things. And so I think you do raise a good question. How do we serve these individuals who are really struggling, really needing help, yet aren't necessarily meeting criteria to remain held, but have other needs that are unmet?
Because so many of them, once they go in front of a psychiatrist, they know how to act for that moment.
There are telltale signs. First of all, we have to remember that mental health and addiction are medical problems, and therefore they need to be treated like medical problems. Just like diabetes and other chronic medical problems, if you don't do the treatment, you're not going to get well. You're going to decompensate. And most of the people, especially in chronic mentally or chronic mental illness, treatment is so very important. Medication, thank God we now have medications to take care of this illness. And the problem is, just like other medical problems, patients do not take their medications consistently. They get angry. They think that they're feeling better, so they don't need to take the medication as if it were antibiotics. So it is so important to deal with them like you're going to deal with someone who has diabetes, to make sure that the treatment is implemented, and to also be mindful that as human beings, we hate taking medications. But the important thing too, especially for the patients and their families, is to make sure that they do understand what the illness is all about. It's not the illness that's going to define the person, but it can be in remission as long as the patient does the work too.
And I think I would like to add with that, especially from a cop's perspective, 5150 oftentimes gets interchanged and meant with applied to somebody with mental illness, but it's not. It's a codified statute in the Welfare and Institution Codes that lays out criteria for a hold. And so that doesn't necessarily apply to somebody who's going through a mental health or mental health crisis, because it's very specific criteria. So when we apply 5150 as a general term to somebody who's experiencing some type of mental health, it actually does create a stigma. And I think you touched upon it. What we end up doing when we try to do a 5150 for someone who's not 5150 is we systemically train them to how to get by and subvert the system which is put in place. And so words do matter, especially when it comes to something, that actually is giving criteria to hold somebody against their will. And, especially in law enforcement, the days of us tackling somebody, sir, this is for your own good, please comply, that's done. Those days are done. And we're not going to engage in that anymore, because that's not what our community or that person needs. So I feel kind of passionate about that, to make sure that the verbiage is correct, because I don't want that stigma attached, because it also puts an unfair expectation on law enforcement and behavioral health as well.
And we have to remember that in the 5150 verbiage for danger to self and danger to others is the imminent danger. So the patient may have acted out or tried to hurt themselves 10 minutes ago, and then when they're evaluated, and I agree with you, they can pull themselves together, especially those who have been through the system many times. They know exactly what to say. Yeah. And, it's almost like it puts the evaluator, the mental health provider, very little choice, because if they ask them, do you have plans? And they said, no. So that means it's not an imminent danger. Are you going to hurt someone? No. So it really is, the verbiage, I agree, needs to be revisited and reevaluated.
Thank you.
Kim, I just want to validate too the difficulty that comes with having to, for running a facility and having to make decisions between an individual's treatment and the treatment of all the people at your facility. That's not easy. Something that facilities in this field have to try to work through, and it's hard. And I just want to validate that. So thank you for sharing. Kelly?
Good morning. My name's Kelly Johnson, and thank you all for being here and for all the hard work you're doing in the community. And just as you were speaking about vicarious trauma and officer wellness and difficulties recruiting, I'm wondering what you all think. What can we do better? How can we do better to support our behavioral health workers in the community to keep them from burning out, especially those that have high stress and doing crisis work? And how do we keep those folks in the field here?
We have, we've come across the trauma-informed organizations, wherein the organization is trained to identify trauma. And part of that, too, is to be mindful and sensitive to the trauma of our own co-workers. And I think it's very important that we really be mindful, because as we now know that trauma can start at the very early age. The adverse childhood experiences has predicted how many mental health, addiction, medical problems it can cause. And that's not only for our patients, that's also for our coworkers. And it's so important to be, to bring that in the open and to train them about that.
Thank you.
I can just say, and I don't think there's an immediate fix to that. I think this is long-term work, and that's, at County Behavioral Health, we're certainly recognizing the importance of staff morale and staff retention, and also how our branch culture impacts that. And so, we've engaged in a number of initiatives around how do we change the culture of our branch, so we're with one another in ways that really sees each other as human and kind of recognizes trauma and vicarious trauma and secondary trauma, and that we care for each other around that. Again, that's not a fix that's here tomorrow, but it's, I think, a longer term commitment to how we are with one another.
Another practical thing that we do is that when a traumatic event happens at our at Waterfront, is we meet with all the staff and decompress and talk about it as a first step.
Mm-hmm. That's so important. I think sometimes the people that lead those are forgotten about, though.
That's right.
Having been that person.
Yes. Yeah.
Well, and I'll just kind of reflect back to you, Kelly. I think you're very key in this work. I think you do this very well, that you engage with people and you lift people up and you make connections and you make people feel seen. And that's the work that retains people and keeps people committed. So I would thank you for your role in this.
Thank you. I just wanted to highlight it because Chief O'Rourke had said that cops aren't very good about taking care of each other. We aren't either in behavioral health. And I think we, myself included, can do better. And I just wanted to highlight that.
Doctors
thank
are the
you.
worst.
I was just going to hit my button and say that.
Hello, I'm Alan Lowry. I have kind of a peripheral interest in this subject, but I speak thinking of myself more as a member of the public. I was interested in the discussion this morning about the process and the cooperation and the storytelling. But from a public perspective, I think the real question is, what are the results? What are the measures you look at to judge how you're doing? And what can the public expect? What are the resource needs that are being met or not being met? And that general question, the results.
Just so that everyone could hear, I'm not sure how good the mic was there. What I'm hearing is kind of what metrics do we use to measure success, and whether or not the funding and the energy that's being put into some of these programs is in fact effective, and how do we demonstrate that? Does that sound right? Okay. Panel?
The problem is we talk a lot more about what went wrong and what bad things happened, but we do not talk about what good things happened and the result of the crisis intervention and so on. And I really think that with the community, different organization, I think the media would be very helpful with this in featuring things that happened well to the community.
I agree that we could do better lifting up positive stories, but I think your question is about what is the data? Like, how do we know that really we're making a difference? And Dr. Goldberg referenced it a little bit in that we're seeing less people placed on 5150s, and we're seeing less people that are getting to that more acute crisis. So internally within County Behavioral Health, and I'm sure other organizations as well, we have data around that. What are the number of 5150s in a year? How many go to the emergency rooms? And so those are the metrics that I'm looking at from my perspective over time to see if the work that we're doing is actually making a difference.
And I just want to add on to that too, that any time we get grant money to fund an initiative, there is always metrics associated with it to ensure that the money is being used appropriately and that it is showing success with it. Otherwise, you're going to lose your funding. We have to have that data in order to continue that. So there is certainly pressure for improvement and to recognize areas where we can improve. So, there is a lot of it that is data driven. There's no bones about it, but it's absolutely critical to the success of any program anywhere.
And I believe that most organizations, including nonprofit, the public has the right to ask for the data. And you certainly can ask.
On Open Doors side, a lot of our data, of course, is healthcare driven. Our primary mission is actually people's healthcare. But what we've found is that folks who are struggling with mental illness, their level of other healthcare is a really good proxy for how well we're doing on these interventions. Because if you're really spending time cycling in and out with law enforcement, in and out of the county and so on, what's not happening in the meantime is we're not meeting other healthcare measures we're held accountable for. How is your blood pressure? How is your diabetes? How are you doing on some of the big chronic diseases? And so those are part of the way that we measure that. I think one of the other things about it, because it's a super valid question, we put together strategies, funding's drawn down, we put together things that we, at the front end, feels like it's working. We see less of certain things, but is it working overall? And this is where maybe it's time for the community, because we've had prolonged and sustained interest in these challenges, is to create a community dashboard with the agencies in question, all the community partners being able to contribute de-identified data, information about their successes, and come up together as a community with a panel that we think demonstrates whether we're succeeding or not. It would help us analyze, are these efforts truly paying off? Sometimes something seems to be working because it's moving it in one sector, but it's actually shifting the problem rather than solving the problem. And that's usually does only come out when you get hard data in front of folks and you look at it comparatively. And so that might be something that all of us as community partners, maybe with the help of the counties and the cities, can begin to look at together.
From a law enforcement perspective, data is usually criminal statistics. And so that, again, is the very negative side. One of the things that I've seen from Meskwaki Tribal Police in Kansas is they actually have data metrics to be able to measure in their department successful interventions. So as my department continues with crisis intervention training and as we continue to become trauma informed, we want to be able to develop that metric of what a successful intervention is that prevented an arrest, that prevented a use of force, that resulted in a positive outcome. But we all have to be on the same page, especially as law enforcement kind of blazes new ground into how to measure successfully a trauma-informed approach.
Thank you. Just being conscious of time, we'll do the last two folks that are standing, and then we'll take a break, and then we'll move on to the next panel, okay?
Okay, thank you. And thank all of you for being here today and taking your Saturday to what you could normally use to decompress your stress and come and communicate with the community. I was heartened to hear Dr. Goldberg talk about the proximity of January 1st through 26 in terms of getting a lot of the SB 43 and the Prop 1, the goals of those bills and propositions actually implemented. I think it is coming real fast and there's a lot to be done. So it's good to hear that. A quick question and then more of a broader question. I'm wondering with St. Joseph's, have you folks considered splitting up your ER and having a psychiatric emergency room as opposed to a combination? I'm sure it comes with logistical challenges, but probably would be nice for staff and patients. I'll just leave that, then you can answer it whenever you want. But the broader question is, do you folks think it would be helpful to have a quantitative needs assessment of what this community needs in terms from a facilities standpoint? And Emmy's brought out, the challenges with staffing those facilities, but I've heard in the past, estimates on how many beds we should have per 100,000 people in population for acute psychiatric beds, but there's also the step-down beds and crisis residential and all those different types of treatment, not modalities, but facilities that provide the treatment. I'm just wondering if you think it would be helpful to actually assess what we have in the community now and what we would like to have. Anyway.
I can just add or respond to that second part. I do think that there is some data that statewide data and local data that we have referenced in the past. And I believe at one of the Board of Supervisors meetings that Paul Bignacki shared some of those recommendations. So maybe that would be worth us pulling up again. We do have, many of you already know, some plans in place to move towards meeting some of those metrics and those needs, including the Behavioral Health Crisis Triage Center with Mad River, the crisis residential treatment facility that Willow Glen is contracting with us for in Sorrel Lee, for a couple examples. So I don't know if the data we have currently would be sufficient to what you're asking, but that might be worth looking at least at as a starting point.
To answer your first question, it has been looked at. There are space constraints. There's not a lot of room in the hospital, like the physical plant right now. And then there's always licensing concerns as well, that you have to kind of get the beds licensed for that particular care. So there's a lot that goes into that. But as the physical plant is right now, there's really not space for it. I know with the prior expansion, the ED had gone from 8 beds, and they said, well, let's just we'll add another 12 beds, and I think that'll kind of handle us. Yeah, it handled it for about 1 day. It's like it immediately all 20 beds are filled, and it's just been that way. We could expand the department to 50 beds, and they're all going to be filled. It's just kind of the nature. I would love to have kind of a separate unit there. But I think right now, as we have discussed, I think there's just not physical place to actually do it.
I suspected that would be the answer. I've spent more time than I'd want to in your ER lately, and I had to, kind of had sitting in a bed, was able to see what was going on, and it just seemed like it would be nice if you had more specialized area, but the space, you couldn't really expand into your parking lot because there seems to be an issue there as well with space.
There's multiple space limitations kind of based on the actual kind of physical plant and plot that we have. So, yeah.
All right. Thank you. All right. Last question for this panel.
Hi, my name is Fire Phoenix. I'm the lead community ambassador for the city of Arcata, and I more wanted to answer this gentleman's question about how do we measure what kind of effect we have. And so the community ambassadors are sort of a layer between the police and the people. We go out and we work with the homeless. We talk with people, get to know them, their backstories. We try to connect them to social services if we can. We pick up all the trash in town. But a lot of it is simply being kind to people and just getting to know them, getting to know their names, their stories, letting them know that we're looking out for them, for their safety, checking in with them every day. So just some of the stats we have. We've been around for 1.5 years, and we compared our last year of the ambassador program with the year before.
Fire, I'm sorry to interrupt. I do want to make sure that we're staying on track with kind of what the panel's oriented for.
Okay.
I'm sure I've heard excellent things about the program, and I would love to have another space to share that, and maybe in future town halls we could have you all come and table.
I'll share the information with this gentleman.
Okay, that would be wonderful. Thank you. Did you have a question that you wanted to pose to the panel?
Not really. I just know that we're all doing the best we can, and we're working together as best we can, and it's tough. We don't have enough resources. Mm-hmm. Thank you all.
Absolutely. Thank you. All right. Well, panel, thank you very much. How about a round of applause, folks? All right, so we'll take a 10 to 15 minute break here, and feel free to step out, check out some of our wonderful community partners and tabling, and then come on back for the lived experience panel. Thank you, everyone.